long and short of it, so I'm going to talk about depression, self-harm, and suicide in children and adolescents. This is a talk, it's similar to some previous talks I've done, so if any of you heard previous talks on this, apologies. It's the same kind of format. I'm a child and adolescent psychiatrist. I work in St Thomas's Hospital and the Evelina Children's Hospital. We cover accident and emergency, and we see around 250 cases every year of mostly teenagers, but children as well, who've self-harmed or report suicidality. I previously worked as an adult psychiatrist in liaison, so actually where we saw volumetrically a lot more of kind of self-harm and suicide, and I'm going to kind of highlight a little bit the differences between adults and children, just as a way of kind of, I think, fleshing out and understanding risk a bit better. So from the beginning, so normally I start this talk, and it's obviously we're in a slightly weird COVID situation where we're working in this particular format, and normally when I do this talk it's much more of a conversation. So all kind of contributions are really welcome, and I'll probably ask you guys a lot of questions about what you think. So either unmute or if you want to send something in the chat box, where's the chat box? There it is. Then by all means do so, and then that would be a way of kind of discussing, and please feel free to stop me at any point and ask questions. So hello to Catherine already, and Katie sent a message. So nice to see you again too. So then normally I start off and do this this chat with thinking about, now how do I change slides? It was working, it's not working. Where are we going? Where are we going? Where are we going? Slides. There we are. Perfect. So I normally start off by saying, imagine I felt totally suicidal. Imagine if I said to you that after doing this talk, I'm going to walk out into the road, walk on top of a bridge, and jump off the bridge. And that's that. And I've made my decision, and I've written a note, and that's what I'm going to do, and that's all there is to it. I was interested in what your reaction might be to that, and how you might, respond to me literally in this context, saying that to you, and whether you'd be worried about me in that situation. And just as a kind of starting point, I don't know if there's any kind of instant where you think I was a high risk, whether you think I was a low risk, and what you're making that decision based on. So I don't know if there's any thoughts you might have about that.
Hi, Ben.
Hi.
Hi. Hi, Simon here. Hi.
Hi, Simon.
So probably be trying to contain my own panic. Be very interested if you'd had any previous suicide attempts, previous self-harm.
Absolutely.
Any peers who have self-harmed or attempted or completed suicide? Any family history?
Yeah, absolutely.
It'd be kind of the risk assessment questions, really.
Yeah, but it just from our initial interactions and literally what I've said to you, without knowing any of that, are you worried or not worried?
Too early to say.
Too early to say. Okay, but is there anything about what I've just told you and me speaking to you now that makes you think high risk, low risk? Just jumping off the top of the page, Simon.
You've written a note, so that implies some forward planning.
Yep.
And some serious intent. You've got a mechanism in mind, i.e. the bridge, and the mechanism is a serious mechanism. If you were to actually jump, you stand a good chance of succeeding.
Yeah, absolutely. Anything that makes you think I'm low risk?
I guess the fact that you've told us perhaps would not be entirely consistent with the plan or the intent.
Absolutely, absolutely. And any other factors in how I'm talking to you now?
You seem quite upbeat.
Yes, Absolutely, I'm very upbeat. I mean, not only from speaking to you and the kind of, but what you're highlighting there. So between the 2 or 3 comments that have already been made, you're highlighting the kind of the different domains in which you're appraising my risk. On one hand, I've written a note. I've got a very clear plan. It's a probably quite a lethal method I'm suggesting. The other hand, you're saying my mental state is upbeat. I you know, in what you know of me, in the little moments what you know of me, that my mood does not seem to be congruent with the things that I'm saying. And this is the point I kind of want to get to in terms of actually assessing risk in teenagers. So I'll do a slide. How do I do slides? What am I doing for slides? What am I doing wrong?
The bottom left, I think.
Bottom left.
There's like a slide mover on a bit.
So what I'm trying to say in this, sorry, thank you very much. What I'm trying to say when we're thinking about risk assessment and is we're balancing up, and the way I think about it is these 4 domains. One is the history and presenting complaint, literally what the patient is telling you, and the basis for that, you know, what method, what they're going to do, final acts or gestures, the kind of things that Simon's highlighted already. Simon also mentioned past history, what I've done previously, had I done this before. The third thing that was brought up was that I was upbeat, and that my mental state was not congruent with the kind of things I was saying. And the fourth thing, if I push it more, what I would highlight to is my social demographic profile. I'm male, I'm 43, you know, I work as a doctor. There are a number of things that are coming along with my socio-demographic profile that may increase or decrease my absolute risk of completed suicide. So when you take a history from a patient to try and think about their suicidal risk, try and think about it in these 4 domains. There's what the patient is telling you, the history of presenting complaint, their past history, have they done it before, have they got depression, have they, you know, what have they done previously, their mental state, and their social demographic profile. So, you know, what you might imagine in a 9-year-old girl is very different in a 65-year-old man. And the art of the risk assessment would be to balance up these 4 domains, because what we're trying to do, you know, and you might say that 2 of these domains are dynamic risk factors. So the presenting complaint and the mental state examination, they change every day. You know, what you might be thinking, feeling, and behaving like will change every day. Whereas the past history and the demographic profile are static risk factors. So if you have had a serious suicide attempt 20 years ago, that will always be on your record. That will always be increasing your risk, but it won't change. And the fact you are male or female or employed, unemployed, though, well, employment probably less so, but various things about your age, for example, these are pretty static risk factors. These will be things that don't change in the way that make a difference, given irrespective of what you're saying. So when we talk about the kind of classic way we think about it in adults, and I think this is the kind of stuff you've brought out already, these are the kind of ways in which we populate this table to say this person is or they are, this person is or isn't a high risk of completed suicide. And the kind of things you've touched on already is the degree of planning, the final acts or gestures, so writing a note, planning against being found, whether you've picked a particularly lethal method, whether you've written a note, the kind of method you've picked. The past history is any psychiatric diagnosis, so even if you've got bipolar or schizophrenia, depression, drug abuse, all of these kind of things will be increasing your risk of completed suicide. We know that medical illnesses, things like cancer or an HIV diagnosis, will increase your risk of completed suicide. A previous history of abuse, or a family history of completed suicide, so that actually, you know, and if I was sitting in front of you, we'll talk more about this, but a family history of completed suicide confers a genetic risk in that you may have high risk of inherited mental illness, but also there's something about a family history of suicide that actually decreases the unacceptability of this as a method of managing deep distress. So somebody close to you, family member or arguably friend, and I think this was mentioned earlier, it makes it less unacceptable to commit suicide, which I think is a very powerful thing. Then we think about the mental state examination. So am I hearing voices telling me that I should end my life? What's my mood like? Have I got delusions that I should die so everybody else should live? these kind of things, the mental state examination. And then lastly, there's the stuff that you guys all, would associate, broadly with kind of the social determinants of all kinds of different health problems, but low social class, unemployment, being male, your age, and so on and so forth are predictors of completed suicide. So a combination of these domains is the way in which you want to try and think about the information you want to elicit to assess somebody's suicide risk. So I'll put some questions to you. So that's obviously the adult picture, which is in many ways quite similar to the adolescent picture. But if we think about the adolescent picture, just going to ask you a few questions to see what you think. So we're talking now about self-harm, and this is based on an international study. I think it's probably about 5-10 years old now. Who self-harms more, boys or girls? Do you want to just put that in the? You can put that in the chat, or you can shout out. We've got girls in the chat. Okay, and what percentage of boys and girls do you think self-harm? Just make a stab. Guess. 15. Okay, Casey says 15. Emma says 15. Boys 10, girls 33. Strong. 1 in 3 girls, Sarah Sturrock says. Which way? Okay. Okay. Depends on age group. Girls 10%. Okay. So we're going between kind of around 1 and 10 for boys, and about between 10 and 33 for girls. Okay. Depends on the definition of self-harm, I suppose. Yeah, that's a very fair point. So, I mean, I'm looking at probably more clinical definitions. So you're actually doing something to physically hurt yourself, rather than whether you say, unsafe sex is a form of self-harm, which you could argue possibly is, but very kind of self-directed inflicted injury is a fair question. Now, in a study of Australia, Norway, Belgium, England, and Holland, which country do you think had the highest, and which country do you think had the lowest? Holland lowest, kind of liberal, progressive Dutch. No idea. England highest. Get out the COVID charts, essentially. Okay. Next question. Which is the most popular method in teenagers of self-harming? Cutting. Okay. And can I get what the second most popular method is, or what the most common methods? And question 7 then. What percentage of those who self-harm have done so before? %. So Simon, Katie has to dash. 50%. Okay. And then a tricky question that often comes up: what percentage of teenagers who self-harm wanted to die? Catherine says 80%, and that's 80% to question 8. I'm taking it. Okay, 20%, kind of a large range. Males higher than females. Okay. Okay, I've got a few more questions. I'm saying 10%. Okay, so quite a range of different views there. We'll come on to the answers in a minute. There's a couple more questions. How long before self-harming did teenagers decide they wished to self-harm, do you think? Generally an hour, a week, more than a week? Is somebody trying to talk? I'm not sure. Nope. Generally an hour, people are saying. Okay. Next question, where's the commonest setting for self-harm? Okay, so most people, home. Often when I've done this talk, people are very specific and they say, like, the spare bedroom. Okay. And then an interesting question, what percentage of self-harm comes to hospital? So you guys are saying very low, 1%, 5%, don't know. Okay. So let's have a look through the answers. So this is probably about 5-10 years ago, international study. I think it's probably increased since then. So the first thing to say, your answers are very close to being what the data would have found. Males 4.3%, females 12.6%. I think there's been studies quoted recently where the overall average is about 12-13% in the UK more recently. But you're looking at about 1 in 6, 1 in 7 teenagers, which seems an awful lot. And when I think back to being a teenager, I wouldn't have appreciated it there was as much as that, but it sounds like it has increased. The sense clinically we get is that it's a lot more than that. Holland has the lowest, and England and Norway have the highest rates of self-harm. Normally, if I was seeing you face to face, I'd ask you to have a think about why that might be, and feel free to add any thoughts on the chat about why you think some countries have higher rates than others. It's quite interesting when you get into the kind of more sociological reasons behind self-harm and completed suicide. In terms of the other questions we were thinking about, so the most common method is cutting. You're absolutely right. And the second most common method is an overdose. Sorry, going back a bit, Catherine says structures of social and family support. That's a really interesting point. I think there seems to be a bit of a trend that Southern Europe is less than Northern Europe, and whether the perception is there's something about larger Catholic families and kind of larger multi-generational families being around that may be protective. One of the difficulties in kind of appraising that is that often where it's less, it's often because it's less recorded, and it's less recorded because it's more stigmatized. So that there's a kind of it's difficult to unpick whether it's a real difference or a kind of a difference due to measurement. But I think that's certainly what Catherine's saying there is a totally valid argument. There's less numbers in kind of low and middle income countries, but again, that might be about measurement. The rate of completed suicide in adults in Malawi, where I've worked a little bit, is actually pretty similar to the UK. And there's lots of reasons why that might be inflated or hidden or vice versa. So it's difficult to unpick that. But there are lots of sociological reasons why that there are different numbers. So carrying on, so we said cutting was the most common, overdose is the next most common. Girls self-cut more than boys, and girls overdose more than boys, but boys do everything else more than girls. So self-harming via cutting and overdosing is predominantly more female behaviour, but boys tend to do more serious, more dangerous, and everything else. I think somebody said about 50% of those who self-harm had done so before, so that was pretty much bang on the money. And just as an extra fact, and repeat self-harm associated with multiple methods or cutting. So if you do lots of self-harm, you do lots of different things. When people ask about, and I think this isn't a world away from what you said in the chat actually, your reasons for doing so, in adolescence, the number one reason is relief from a terrible state of mind. So, and this is, I think, a bit different from the kind of the adult population. An adult who presents with suicide or self-harm is more likely to associate that with a wish to end their life, whereas in an adolescent, it has other kind of drivers towards getting there. And I think somebody said 80%. I think somebody said 20% in terms of wanting to die being a reason for it. From this study alone, it's about 60%, which is likely to be ups and downs, but maybe quite close to the truth. And then punishing self appears to be another reason that people cited an awful lot. Quite rightly, you identified that it was in teenagers. It's much more of a spontaneous act that happens just before people think about it and then do it, rather than it's something that's much more planned. Boys tend to be more planning than girls do, and girls seem to be a bit more impulsive with regards to this. Quite right, you said that home was the commonest setting as kind of extra information. Some of it is under the influence of alcohol and drugs, but actually compared to adults, that's less. And alcohol and drugs seem to be more associated with boys doing it than girls doing it. Probably, it probably is a function of boys taking more alcohol and drugs during adolescence than girls do, amongst many other reasons. This is possibly the interesting element from a clinical point of view, that hospital attendance is only 12% of all self-harm. So the vast majority of self-harm goes on without the need to without going to hospital or the need to go to hospital. So that's an interesting point, because I think one of the things that we always carry as clinicians is this, and I'm sure we'll talk about it a bit more, is this idea of attention seeking and the drama around self-harm. But actually, in terms of the kind of hospital or medical related attendance, most of it is very private and doesn't have quite the clinical journey that we see. And obviously, we only see those who do come to hospital, or certainly those who come to hospital in the context of having done it. That said, there is a social element to it that other people are aware in 75% of cases. So there is something about what self-harm does within somebody's kind of social network that is important as well. That it triggers, help, support, whatever you want to call it. That it has that function as well as being a kind of individual function as well. So going back to how we kind of risk assess for both self-harm and completed suicide in teenagers, the differences from adults, or the differences from what we learn about most often, is that in teenagers we know that it's much more impulsive. It's much more to do with relief from tension or stress and self-punishment, whereas in adults it has much more suicidal foundings to it. The other things, to kind of cut to the chase a little bit, in terms of the past history, while we'd be looking for a diagnosis of schizophrenia or bipolar in an adult, actually in an adolescent, the psychiatric conditions that increase the likelihood of self-harm are conduct disorder, ADHD, and eating disorders. And I put as our number 2 is no diagnosis. And I think that this is really important. We'll come back to this. Is the idea that actually that in adolescence, self-harm is not actually, broadly, a psychiatric diagnostic related behavior, that actually that not having any psychiatric diagnosis is more likely when you meet people with self-harm rather than having one. The other thing that's very different in terms of risk of repeated self-harm is that it's a different social demographic profile. There is an association with lower social class, but what is different is that there is also an association with high social class. And actually, this is, certainly in St Thomas's, we get a lot of, very academically, socially able families, very social class 1 families, who come in, and the self-harm is associated with the kind of the high achievers, the pressures of academic pressures and so on and so forth, just as much as it is to do with conduct problems and drugs and alcohol.
Ben, can I ask a quick question about the past medical history of no diagnosis? Is your feeling that that's because these young people have a diagnosis but aren't yet diagnosed, as it were, or have a, or is it more that self-harm it could be described as a kind of normal developmental part of an adolescent development?
The latter, I think. I think that's the big sociological question of the day, which is that even if we don't call it a normal, as in non-clinical, I think there's something about it that is more associated with no psychiatric illness, and that it's a behaviour, and that there is a culture we're going through at the moment, which is where this is a much more culturally acceptable way of expressing distress than it was 30 or 40 years ago.
Thanks.
Is the short answer. It's a very good, but I mean, I think that's the really good question. I think that's the question that a lot of researchers are trying to answer and should be trying to ask more, because it's a very, very good question. So to add on to that, what we've just been saying about presenting a complaint, the kind of things that teenagers report, and this is a kind of an amalgam of kind of more qualitative research, is to say, well, why did you self-harm? And besides the kind of pure suicidality, these are the kind of things that are commonly said. So distraction, escape from feeling trapped, relieving tension, inducing a feeling of calm, self-disgust, guilt and shame. So I'm rattling through these with a degree of kind of blasé-ness about it, which is, you know, in those moments these are very kind of obviously very deep and very, very strong feelings that the patients we look after feel. But they are you know, that these are the kind of things that you'll hear spoken about very, very commonly as the reasons why people self-harm. You know, besides just saying this, the other thing that's very interesting is that this does link on to kind of the neurobiology of understanding self-harm. Now, that's not to say that the neurobiology is predictive of a diagnosis per se, but that there is something about a self-harming behavior that actually holds a basis in kind of neural activity. This is a study about people with borderline personality disorder, and I'm not saying there is you know, that everybody self-harms has a borderline personality disorder, quite the opposite. But there's something about different brain areas requiring some kind of resolution to distress in certain ways that actually predicts self-harm in a way that's really interesting. And that some people are wired in a way that they have, you know, when they're in a heightened emotional situation, they need certain kinds of ways in which they process that heightened emotion that might help. And there is a biology behind kind of opiate receptors and how that, you know, going through pain pathways actually helps control distressing feelings, which you know, irrespective of that relates to a clinical diagnosis, it's an interesting process. It's a really interesting process. And I suppose the way to think about this a little bit is that we all have maladaptive strategies at different times. Now, you might not call it self-harm in absolute terms, but, you know, if you bite your nails because you're nervous, or if you, you know, you pick off a scab preemptively before it needs to be picked off because there's something kind of slightly exquisite about the pain sensation there, or, you know, various other things that some people like to punch a punch bag, or, you know, play a kind of contact sport, or, you know, ultra runners or something like that. There's something about physical pain sensation that can actually be quite relieving in terms of relieving kind of tension and emotional stress. And there's a biology behind that, irrespective if you call it a diagnostic issue. The other things that I think come up an awful lot, and one of the other big questions in this area is about the other reasons for self-harming, about this kind of social reasons. And in a sense, and we'll come back to this, is this idea that firstly you have to do an almost systematic inquiry into the young person's life when you're asking them about their brothers and sisters, when you're asking about their parents, you ask about their friends, you ask about school, you ask about kind of sport, you ask about music, you ask about internet history. And you almost go through kind of a list of things mentally to think about the areas in which they may be struggling, that if you didn't ask about, they wouldn't necessarily volunteer. But the other things that come up very commonly, very, very commonly, are kind of arguments with close friends, family arguments, getting drunk, bullying being a huge thing. And the more serious end of the spectrum, you've got kind of neglect or abuse or something like that. And I think the big change from how I remember being a teenager to today is the introduction of the internet, and we can talk and think a bit more about whether and how that plays a role in presentations at the moment. The other thing that I think is very, very different or very difficult is how you assess depression in teenagers, and depression being a very strong driver of completed suicide in adults, a driver of self-harm and completed suicide in adolescents as well. What's the difference between a depressed teenager and a teenager? I'll leave it. Any answers on the chat would be very well received. Irritability. Yes. Anhedonia. Social isolation, unusual sleep. Unusual appetite. Yep. Yeah. So you've got a number of different things there that are highly pertinent, and I think both, I would say, what's the difference between a teenager and a depressed teenager, and also what's the difference between a depressed teenager and a depressed adult. And I think you guys have pointed to some of the most important things there. So social isolation, anhedonia, going through here, irritability, and then things like kind of appetite and mood. Now, how do you kind of there we are. So the kind of things that you know, when we kind of ask this question, is if you've got a kind of slightly grouchy goth sitting in front of you, they're interested in kind of talking extensively about their feelings and so on and so forth, is going to be very, you know, with any teenager, that's a challenge. I would be less worried about somebody who's talking about death, has got death written on their wall, as kind of dressed extensively in kind of quite morbid and depressing looking clothing, compared to somebody who's just not washed or just not showered or just not taken that interest. The teenager who spent hours kind of painting their nails and dressing of a particular kind of subculture is somebody who's actually probably quite mentally healthy. The one who's, you know, just in a t-shirt that just, you know, hasn't looked after themselves is somebody I'd be worried about an awful lot. The kind of things we'd be interested in, the kind of changes in peer relationships, and if you take out the kind of, you know, the autistic group who struggle with many peer relationships, a change, somebody who was quite social and is then less social. Social withdrawal in and of itself, so, you know, you'll hear the stories of kids who are just kind of sitting in their room playing computer games all day. I mean, that's a lot of kids, but a change in that regard. Dropping academic performance. And then somebody said about appetite and sleep. And while it's not absolute, the adolescent depression looks more like hypersomnia, so oversleeping and overeating, rather than what you see classically in adults, which is kind of poor sleep and poor appetite. So the adolescent might look slightly different in that regard. The other thing, and this was one of the first things you guys said, was anhedonia. So the loss of the things they normally enjoy, and that's really, you know, somebody who gets really interested in kind of morbid music or morbid art or stuff like that, that's great. Don't worry about them. Worry about the people who've lost interest in anything. That's much more of a worry from a kind of assessment of depression point of view. So that's the kind of things that we want to think about. So when we're thinking about the mental state examination in an adolescent, we're looking at something that might be slightly different from an adult depression and might be slightly different from kind of a non-depressed teenager. And I think was it Simon who said irritability earlier on, so which I didn't mention actually, but you're absolutely right. So the increased irritability is seen as another sign that somebody might be depressed. You might notice somebody who's much more angry, short-tempered than somebody who's necessarily going to say to you, I feel depressed. And I think this comes out in the I think this comes out in the way that you ask teenagers about depression. It's not very often that I hear teenagers say that they feel sad or they feel upset. They normally say they feel bored or they feel angry or they feel, you know, pissed off. That's the language that I notice much more with regards to depression rather than the way it be expressed in an adult. So going back to what we talked about before, that in terms of the past history, previous self-harm being a risk factor for future self-harm, which is, you know, I guess kind of self-explanatory. The diagnosis, we talked about conduct disorder, we talked about emerging borderline personality disorder. You may be, you know, the kind of psychiatric view is that you can't really diagnose somebody with a personality disorder before they're 18. However, there are, without question, kind of 13, 14-year-olds where you can see what you think is the trajectory of somebody with a borderline personality disorder, kind of increasing self-harm, mood swings, risk-taking behavior, kind of intense interpersonal relationships, and so on and so forth. ADHD is a risk factor, and then you're looking at kind of, you know, have they been admitted psychiatrically before, and is there a history of quite more kind of serious abuse and things like that. So going back a bit, I said, we think about a systematic inquiry, and that's one of the things that I think, you know, you as paediatricians, or if you work in accident emergency, will be something I would recommend, which is about how you go through the different areas of this child or adolescent's life and ask them, you know, and purposefully ask them about each parts of it that they may not tell you by themselves. If you ask a 45-year-old adult, you know, why do you take this overdose? And they'll say, well, because, you know, I'm grieving my parents' death, or I've lost my job, or I've done this, or this has happened. And connecting the event with the self-harm is much easier for an adult. The other thing I would say, broadly, I think it's very difficult for adolescents and maybe children to answer the question why. Why did you do that? Because I think there's less of a connection between kind of cause and effect that makes sense for a lot of children. And I think that's a developmental question. If you look at it more kind of philosophically, that our ability to account for our actions is we have, there are interesting kind of cognitive processes to do that. If I asked all of you why you chose to be paediatricians, you've got an answer that you can trot out for me that's quite appropriate and thoughtful and represents the kind of professional relationship we might have. However, if you're having a really shit day and a close friend of yours said, why have you chosen to be a paediatrician, you might answer in a completely different way. And knowing how you can answer or draw causal links in different ways for different reasons is really, really important. But I think that's more of a challenging for a teenager. So if you say why you take the overdose, I wouldn't maybe phrase the question that particular way. I'd be much more inclined to say, tell us that you took the overdose. What were you feeling before you took the overdose? What happened before that happened? What happened, and so on and so forth. So you build up a series of either events or moods or situations or experiences, and then the overdose happened, rather than trying to link it through a kind of why question. The other thing that's very interesting, I think, in adolescent self-harm compared to adult self-harm, we talked earlier about this idea that only 12.5% of children or teenagers attend hospital with self-harm. There's a very, very interesting question about what the threshold of presentation is. Now, the obvious thing is that the medical severity. So that if you've taken a significant overdose, if you've cut yourself to the point where you're going to need plastic surgery or whatever, that is a clear medical reason that crosses the threshold for why they're coming to hospital. But there's much, much more than that, because as you know, when you've worked in A&E and paediatrics, I imagine you'll see people with essentially very trivial, from a medical point of view, levels of self-harm, but they've come to hospital nonetheless. And there's something about that. What are the thresholds for patients, and what are the thresholds for the family? And what does that tell us? Because the patient might self-harmed 25 times, but they've only presented on this one occasion with a fairly superficial cut. What's that about? And the same for the family. Is that the first time this has happened, and the family just kind of cannot get their heads around the idea that this has happened to their child? Is it that the family can't take anymore, but they've been dealing with this for 6 months by themselves? So that kind of question, I think, is really, really important to ask in child psychiatry and A&E in a way that possibly it's not in the same for adults. And lastly, there's another questions about the role of the internet, and I'm getting to an age now where, like, I kind of get Facebook. I'm on Twitter, but I don't tweet because I have nothing really worthwhile to say. But like, I am lost beyond that. And I think there are so many important pieces of work to be done by, dare I say, your generation of doctors, which is to think about what that means and what it means. Quite simply, when a teenager sends a suicide note online, or post a message up on Instagram or Facebook or Twitter, whether that carries the same weight as writing a letter. Because when I was training, you'd say, did you write a suicide letter? And now you ask a teenager today, did you write a letter? I mean, they would look at you like you're mad. That degree, how do you assess the degree of forward planning or a final act or gesture in a kind of internet communication age, rather than the way that we might have been more familiar with when we trained, certainly when I trained? So there's that kind of question to think about. Thinking more widely about the relationship between the internet and adolescent mental health. And again, this is something that I think it becomes a bit like the debate about whether you have too many hours of TV every day, about the role of dangerous video games in causing mass murders, and there's a degree of kind of public outcry about this, and there are people who are media figures or celebrities, whatever, or academics, who see their children spending hours and hours and hours on the internet and see the difficulty they have in the relationship with their child, and they connect the two. and I think it's difficult to think about that in a more scientific context in some ways. This is a study from Oxford that was published, I think, just before I'd last did this talk, where they looked at the kind of the well-being of teenagers in the UK and the USA, and saying, what percentage of time they spend on the internet, what do they look at, and how does that relate to kind of general scores about well-being. And in terms of, if you did some kind of regression analysis, that the actual variance of the role of tech in adolescent well-being is relatively low. So that it's not to say that, there are suicide websites, that there are kind of these really toxic environments online, but the contribution they play to overall mental health of teenagers is probably quite low. But I think, again, the narrative we get is where this does play a role. So somebody went on, a well child went onto a kind of self-harming website, got an idea, and then did it. That narrative stands out much more strongly than the thousands of teenagers who are looking at all kinds of helpful and healthy things at the same time, who are doing perfectly well. There's a really interesting question about COVID and lockdown and the internet, and I think it's very difficult to argue beyond the fact that the internet has been a lifeline for so many teenagers with kind of milder problems in terms of how it connects them to other friends and people in a way that 20 years ago, if we'd had a lockdown, we just wouldn't. Well, not 20 years, probably 30 years ago, it would not have done so. So I think that possibly some of this narrative is overemphasized. So how we did the time? We're good. Management. I think the main. So I was very much kind of framing this talk in the idea of, like, you are working in A&E or you're working in acute pediatrics and you meet somebody who's self-harmed. What is your role? And I think your main role is to assess the risk, and again, that's based on these kind of four areas, four domains that I think are most important. So what the patient's telling you, what their mental state is like, whether they've got a past history of clinical risk factors, and then their social demographic profile. And these are weighing up those four domains, I think, is really important. If a 5-year-old says that they're going to jump off a building, I'm less worried about them than if a 17-year-old says they're going to jump off a building, all other things being equal. So you're using, if you just look at the kind of social demographic stuff, and that kind of idea of how you weigh up the kind of the level of risk. Your role, I think, your role in, emerging role will be to think about diagnosing psychiatric illness. You will hopefully spot things like ADHD and autism in children. I think spotting teenage depression is something that's going to be really important. And like in your normal work, in your day jobs, spotting depression or anxiety in kids with asthma or diabetes, I think, is an incredibly valuable skill that you can bring to the job that I think 20 years ago we weren't thinking about so much. Our role as psychiatrists, I think, is those top two, and then we have to think about what are the risk factors that are leading to this self-harm. Are there school risk factors, bullying and so on and so forth? Academic performance, do they need more educational support? What is it in the peer relationships? Are they vulnerable? Are they being bullied? Are they being abused? These kind of things. And then I think as a psychiatrist, principally, we're looking at, we're looking for an eating disorder or depression or anxiety, and can we treat those particular illnesses that are increasing self-harm and likelihood of completed suicide? But again, it's going back to what we were saying earlier. It's not that everybody who self-harms, or indeed it's a minority of people who self-harm, who have a diagnosable psychiatric condition. So the psychiatric component is not pervasive. The big question we ask ourselves as psychiatrists is about admission to psychiatric hospital, and this is painting a slightly simple dichotomy between low risk home with more support and treatment and high risk coming to hospital. But the things that kind of play a role in that decision, or I think influence that decision about kind of psychiatric admission, obviously when people have a higher risk of completed suicide. Now in teenagers, when teenagers express suicidal ideation, their risk of completed suicide is lower. There are, it's a teenage suicide is actually a rare thing. That's not said with any complacency, but it's certainly a rare thing that a teenager will go through with this. As we said before, self-harm is less psychiatric. And the other thing that's very different from adults is that generally you have one or two carers available, i.e. parents generally, who are around to supervise the teenager. So you're in a different situation from adults. The other thing that's a particular concern, and this is discussed and argued about a lot in psychiatric circles, is the iatrogenic effect of admission. That actually, if you take a child who may be attending some school, who has some relationship with the family, and you put them into a psychiatric ward, they often do a lot worse. And they're surrounded by people who are often sick or sicker, or sick, that makes their kind of prognosis worse. They copy things. When I was working in an inpatient unit, some kind soul started a hearing voices group for the teenagers, and I think on the first day, 1 out of 10 of the teenagers was actually hearing voices because they were psychotic. By the end of it, they were all hearing voices, and there's something, and I say that with slight cynicism, but there's something about the way in which teenagers mimic each other's behaviour that I think can be quite toxic. So you have to think about that when you admit people to psychiatric hospitals. When you are thinking that something's serious, when somebody is presenting with self-harm, I think there's, it's always the case that we as CAMS should come and do a review, and certainly every kind of potential admission we will be heavily involved in. At the moment, we're quite lucky that there's an NHS guideline, a NICE guideline that pushes towards what we call the 7-day follow-up, where anybody who presents to A&E that we discharge, we have the expectation that the local CAMS team should see this patient within 7 days. Now, they may not continue treatment, but they will do a check-in within those 7 days, which is actually quite a reassuring piece of work in many ways in terms of giving that kind of second view and that guidance. I'm not going to talk about DBT an awful lot, but DBT stands for dialectical behavioural therapy. It's got a relatively strong evidence base for managing self-harm and supporting people with borderline emotionally unstable personality disorder in adults. It's got different components to it that try and aid this idea of kind of stress, tension, relief, managing those complex emotions in the moment and understanding those complex emotions in the moment, that has an evidence base for preventing self-harm, which is really, really useful. The other thing that I think plays into all of our minds as psychiatrists is the bed. I won't say crisis because it's essentially perennial, but there is a limitation in the resource available for inpatient treatment, and we have very sadly sent people to Sheffield and Newcastle because there were no beds in London. Sheffield and Newcastle are perfectly nice places, but there is a that not only does that remove them from their kind of normal life in London, but removes them from everything for a period of time, which we think about. I'm not going to talk about DBT, but just for your information and for the slides, DBT works on kind of 4 strands, one of which is about emotional regulation, which these things to kind of in the moment managing those feelings of wanting self-harm, impulse control techniques, which are known as distress tolerance. Interpersonal effectiveness is, I guess, about improving your assertiveness, and then mindfulness is the 4th pillar of DBT. And there are ways of noticing, if we look back at all of those feelings and those reasons that teenagers talk about wanting to self-harm, these are the kind of processes and that we think about that can help them in the moment of trying to be able to try and avoid that. I was going to talk about just this very briefly, and I thought I couldn't not pay a nod to the bizarre situation we all find ourselves in at the moment. And I'll touch on this just briefly, but maybe we could chat about it as well for a couple of minutes. COVID-19 has brought, maybe more the lockdown than the condition itself, has brought a really interesting set of questions to psychiatry. One of the things we've noticed, and I think this is the case nationally, is that there's been a massive drop-off in the number of A&E presentations of self-harm in the lockdown period. I mean, we saw next to nobody for about 2 months, and we normally see about 4 or 5 a week. So there's something about the lockdown has reduced that. Now, I think your experience in paediatrics may be similar, and it may be that a lot of, respectfully, less severe, less serious medical presentations stayed at home. It may be that people weren't falling off buildings and falling off playgrounds. It may be that because everybody was kind of isolating, there weren't so many infections that brought people to A&E. But there's something also about whether there's, anything positive from the lockdown from a psychiatric point of view that changed the rates of presentations. For me, there's a lot of things about how, you know, you're kind of removing bullying, you're kind of removing academic pressures. You've got a lot of kids who suddenly have a lot more time with their parents in the way they didn't have. That all of those things may have promoted mental health, bizarrely. So certainly the group that I look after, who are kind of school avoiders, socially anxious, and all these, you know, those kind of conditions were you know, were in so many ways kind of more secure during the lockdown than they possibly had been. What's interesting that's happened in the last 4 weeks or so is that there was a significant reduction in adult presentations with self-harm as well, but that has now returned and quite strongly. So since the lockdown's finished, people have started coming back, but that's not true for adolescents. So it's interesting that there seems to be a lag time, either a lag time that teenagers, you know, we're awaiting the kind of the peak of adolescent self-harm post-lockdown, if indeed we are post-lockdown, or whether that actually there's just been a period of time where teenagers were possibly a bit more well for a number of different reasons that adults, you know, aren't, and maybe what we're going to see, you know, down the line for different reasons is a massive increase in adolescent mental health problems that could be about more kind of family matters. It could be about, you know, parental unemployment, about poverty, about social housing, academic achievement, so many different things, but we don't really know just yet, but it's interesting. The other things of note, that the rate of completed suicide in adults in London has increased threefold in the last couple of months. So you've got a lot of people who weren't presenting with self-harm, who weren't presenting with arguably lower level stuff, but who have completed suicide. So normally in London there'd be a suicide every 3 or 4 days, and now there's every day there is a registered completed suicide in London, which is something to be notable about. There are certainly, my experience clinically, and I don't have the figures for it, is that there's been 1 or 2 significant adolescent suicides in which we wouldn't have expected as frequently. So I think the data does exist. I think there's been 25 adolescent suicides in the period of about a couple of months in London South East. No, maybe more widely than that. Whereas there was the same number over about 6 months prior to that. So there's definitely been an increase. One of the interesting things is many of those people weren't in touch with services. But there's going to be an interesting thought and commentary about what's going on and why it's going on. And the last thing that's, I guess, that's kind of pertinent to mental health in these times is about kind of virtual working. And I won't talk hugely about this, but there are questions we're asking ourselves about how you assess risk virtually, how you engender the right kind of patient contact online, that I think remains quite challenging. And we're, you know, I don't think we've got time to talk about that today, but we can think about that anyway. So to bring things to an end, self-harm is incredibly common. We're looking at about 1 in every 7 teenagers. It's not necessarily a psychiatric related issue. It does augment the risk of completed suicide, so we need to take it seriously. We can, you know, rule in, rule out other mental health issues such as teenage depression, and also to say that there are different issues compared to adults, but that we need to think about. And I hope, you know, where you are, there's access to the appropriate level of CAMHS support and supervision wherever possible. Thank you very much.
Thank you so much for that. I guess maybe if anyone's got any final questions, and I'd just like to bring everyone's attention to the feedback. So it'd be really great if you could fill out some feedback for us. It's just in the chat bar. But before we finish up, any final questions?
Ben, thank you. That's been really interesting. I have 2 questions. Are you okay for time? I'll maybe just ask one.
Yeah, go for it.
Just wondered what your view was on sort of a harm reduction advice. So if you're going to cut, make sure it's a clean blade. Here's the signs of infection, that sort of thing.
I think that's it. I think it's. I think the harm reduction movement generally is a really good thing. I think you need to. There's a real tension, I think, between those people who say that you've got to not self-harm at all, and our objective is to stop you self-harming altogether, and that any there's almost this like kind of Puritan view to kind of like we have to stop this, which I think is unhelpful because then it kind of goes underground and becomes harder to talk about. And then the harm reduction thing is this has happened. Let's accept it's happened. You need to do it in a way that's as safe as possible. Kind of reiterating what you're saying. I think I think when you've got a stable clinical picture and you know the person, you know what they're doing and why they're doing it, I think that harm reduction model is great. I think what's very interesting in the adolescent population and possibly the young adult population is the degree to which the self-harm is a communication, because I think a harm reduction model in which the purpose of the self-harm and that person is communicating their distress, then a harm reduction is going to feel like a rejection and is going to lead to kind of augmentation of behavior. So I think I think harm reduction works well in somebody who's stable, who's chronic, where you know what you're dealing with, and you know that this is just going to be the case, and they're not trying to, by telling you about the self-harm, they're not trying to augment your kind of help, your kind of involvement and attachment and support. But if you don't know that, if it's a fluctuating picture, then I think harm reduction will feel, as I said, will feel a bit like a rejection.
That's really helpful, and kind of touched on my other question, which is about the well, the reducing harm compared to the trying to stop the harm, and self-harm as a coping mechanism, really, be it a maladaptive coping mechanism. Yep. Like a crutch, and if someone needs a crutch, you don't take away the crutch because they're going to fall over.
Absolutely.
And wonder what you thought about that.
No, so I completely agree with you, and I think that's absolutely right, and I think I think what I see in the pediatric wards I see is when somebody self-harms, like, oh my goodness, what are we going to do? And actually, you have to kind of, as a clinician, I think you have to just say, no, this is okay. It's not ideal, but you've got to see it as part of that person's kind of coping mechanisms. And I think that if 1 in 7 teenagers is self-harming, then you have to accept it as a pretty kind of normal, if maladaptive, like you say, a maladaptive behaviour. I think what's very interesting is again, it's in the context of these 4 domains. If the self-harming is, if it's not associated with a mental health condition, if it's not associated with real suicidal ideation, if it's not associated with kind of a change in mental state or kind of then if you've got a 65-year-old man who's self-harming, then you take it more seriously and in different directions. So I think there's very much a kind of context, but I agree with you. I do agree with you.
Thank you.
Okay.
Thank you very much. Thanks so much for your time. I will stop recording and end the meeting.
Fantastic.